Good morning, good evening, wherever you might be. We will talk here about surgical problems involving the parathyroids. And there's not many things that involve the parathyroids that aren't going to bring in surgery for some kind of consultation. So the parathyroids have one major thing that they need to do, and that is to sense calcium. And so calcium is going to play a big role while we talk here. So we'll go over the anatomy, where the parathyroids are at. If you watched the thyroid lecture, you should know that they are very close to the thyroid. We'll talk about the physiology, the hormone that the parathyroids secrete, and the hormone that the thyroid secretes that balances it out. And then we'll talk about hypercalcemia as well as primary hyperparathyroidism. And then we'll even though this isn't really a surgical topic, I do want to emphasize the difference between primary versus secondary versus tertiary hyperparathyroidism, because you will be given a test question on that, and it's somewhat delicate in knowing each of those lab tests. So knowing the physiology will really help. And then I'll talk about the parathyroidectomy procedures. So here's our anatomy here. This is the thyroid sort of wrapping around the esophagus. So we're looking from the posterior aspect here. The parathyroid glands, there's two on the superior lobe, on the posterior aspect, and then two on the inferior lobe. And it's not uncommon to have parathyroid glands that are ectopic in other places. So parathyroid hormone is the hormone that's released by the parathyroids. It's really the bread and butter of why the parathyroids exist. This is what they do. They release parathyroid hormone when necessary. And parathyroid hormone is released by the parathyroids, and what this hormone does is it stimulates gut absorption of calcium as well as bone demineralization, more so of an indirect role of stimulating gut absorption of calcium, but directly works on the osteoclasts to allow for bone demineralization. Both of those are going to raise your serum calcium. It also stimulates the conversion of 25D to 125D in the kidney. So remember that with vitamin D, you have to turn it into an active form, and that active form is the 125-dihydroxy vitamin D. So this is the last step. And so parathyroid hormone is needed to convert 25D to 125D and to create active vitamin D. So that's also going to be really important, because 125-dihydroxy vitamin D is responsible for allowing gut absorption of calcium. So again, another place where you're going to raise calcium. Parathyroid hormone also promotes the renal excretion of phosphate. And that makes sense. You don't want to have calcium and phosphate sitting around together too much. Otherwise, they can glom on together and form crystals. Okay, so that's parathyroid hormone. This is the hormone that is released by the parathyroids. Now, we need to have a balance to this. We can't constantly be raising our blood calcium and go on and on and on, otherwise we'd be rocks. So what we need is a balancing hormone, and there is a balancing hormone that's released from the thyroid. So when your elevated ionized calcium gets to a certain point, there are receptors in the C cells which then allow for the release of calcitonin. And so a high blood calcium stimulates the release of calcitonin. And I used to tell my MCAT students, calcitonin tones down the calcium. And I think that works just as good for us too. So calcitonin lowers calcium. So it does everything the opposite that PTH does, with the exception of one thing. So First, it's going to inhibit gut absorption of calcium. It's going to inhibit osteoclasts in bones, so both of those are going to turn off the supply of calcium. It'll reduce calcium. It's going to inhibit renal tubular reabsorption of calcium. So when your kidneys are trying to say, hey, I don't want that calcium to go out in the urine, I'm going to go grab it back. Well, as you put your hand on that calcium, calcitonin slaps your hand and says, oh, no, you don't. And so you don't get your calcium back and it goes out in the urine. So that's going to reduce calcium. But like parathyroid hormone, it also promotes the renal excretion of phosphate. All right. So what about calcium? We can be eucalcemic, as we normally are. We can be hypercalcemic, or we can be hypocalcemic. What does calcium do for us? Calcium, remember, is a 2+ ion. It's a cation, and it's responsible for stabilizing the cell membranes. And so you need to have a proper amount of calcium in your serum in order to allow for stabilized, healthy membranes. Enough calcium in your extracellular fluid, not too much, but not too little, because this is what allows you to stabilize your cell membrane, so your cell membranes aren't tweaking out. If you are hypercalcemic, where your membranes are overstabilized and they get kind of lazy, or if you're hypocalcemic, where your membranes are understabilized and they get kind of twerky, then you have problems. So let's first talk about hypercalcemia. So hypercalcemia is where you have elevated calcium, and now because you have so much calcium, your membranes are overstabilized. So the nerves and the cells, they don't really want to do anything. It's hard for them to do anything because there's so much stabilization around the cells. First off, what you're going to have is neuronal hypoexcitability, and that's a good term to remember because it dictates quite a few different things. So it can cause depression, confusion, fatigue, stupor, coma. Of course, that's, if it gets worse and worse and worse, you'll go from fatigue to stupor to coma. It also causes hypotonicity of the muscles. Okay, so you have too much calcium on the outside, you've got overstabilized membranes, and you can't restart your action potential. And so the membranes are overstabilized with too much calcium. And so you'll have hypotonicity of the muscles, weakness. That weakness is going to be both to your skeletal muscles and to your smooth muscles, so that's going to cause constipation. You'll also have low deep tendon reflexes, and that has both to do with the weakness of your muscles and the hypoexcitability of your nerves. Because there's calcium there, just as it being calcium, you can get formation of renal calcium stones, and also QT shortening. This is sort of lazy heart. So the QT distance is going to be shortened. Okay, so hypocalcemia is where the membranes are understabilized. So now we're tweaking up. We have neuronal hyperactivity. You'll get paresthesias, abnormal reflex, Chvostek's sign, Trousseau's sign, generalized tetany. Your muscles are going to have a hard time relaxing, hyperactive deep tendon reflexes, and QT prolongation. Remember, it's the calcium that allows us to get out of T. So I'm trying to draw it in my head here. QRST, yeah. So it's our calcium that allows us to move from the QRS complex to the T wave. And so if you don't have enough calcium, then it's going to take longer to get from the QRS complex to the T wave. If you have too much calcium, it's going to quickly go from the QRS complex to the T wave. Hopefully that made sense. Okay, so let's do a quick vignette here. A 41-year-old woman presents to your clinic for an annual wellness check. She has no acute issues at this time. Her past medical history includes bipolar type 2 affective disorder and asthma, both of which are well controlled at this time. Her medications include divalproate and albuterol inhaler, which she says she uses about once or twice per month, the albuterol inhaler. She denies history of tobacco, drug, or alcohol use. Vitals are within normal limits. Physical exam is unremarkable. BMP is ordered and is within normal limits, except for a calcium level of 10.9 milligrams per deciliter, which is elevated, slightly elevated, and a phosphate level of 1.4 milligrams per deciliter, which is low. Reference range is 2.5 to 4.5 here. So, we have a patient here with asymptomatic hypercalcemia. Now, she could come in and she says, oh, I've got a fever and a sore throat, and I've got this calcium level here. That's still asymptomatic hypercalcemia. When we say asymptomatic, we mean there's no symptoms present that we could attribute to hypercalcemia. Now, if the vignette was a 41-year-old woman presents to your clinic 6 months following a kidney stone, well, then this would be symptomatic hypercalcemia, okay? So the differential diagnosis for asymptomatic hypercalcemia include many things. So first of all, we are always going to include the number one thing. The number one thing that causes asymptomatic hypercalcemia is primary hyperparathyroidism. And that can be in the form of an adenoma, it can be in the form of just generalized parathyroid hyperplasia, or it can be in the form of a carcinoma. There's something called familial hypocalciuric hypercalcemia. This is not a surgical problem, but it's good to just briefly review. This is something that goes in families, and all it is you have a hard time urinating out calcium, and so that's going to remain in the blood. Sarcoidosis can cause elevated calcium. Sarcoidosis doesn't sound likely in this woman, but sarcoidosis, the reason that it causes elevated calcium is because you get a lot of vitamin D production in the sarcoid cells, in those granulomas. Multiple myeloma, as well as different cancers, can cause elevated calcium. So multiple myeloma, for obvious reasons, you've got a tumor in bone, and so because that tumor is in the bone, it's going to cause breakdown of the bone, so that can cause increased calcium. As far as some of the other things that can cause paraneoplastic syndromes, any of the squamous cell cancers, particularly squamous cell cancer of the lung or of the esophagus, can cause elevated calcium. They release the what's known as the parathyroid hormone resembling peptide. So in that case, you would have an elevated quote-unquote PTH, but it's not really PTH. And then adverse effects of medication, those include lithium, thiazide diuretics, antacids, and vitamin overdose. Vitamin overdose, that would be pretty much vitamin A and vitamin D. One last thing I would add here is, especially if you work with older patients, there's something called the hypercalcemia of immobility, and that's just patients that aren't getting up and moving. They can have a benign hypercalcemia. But that's not this patient. This patient is young, 41 years old, has no other symptoms. She's just got a hypercalcemia. So looking at our differential, some of the things that are maybe less likely or more likely, well, we could probably say that adverse effects of medication are less likely. She's not taking any of these. The paraneoplastic syndromes, those are going to be from squamous cell cancer of the lung and from squamous cell cancer of the esophagus. Those are probably a little bit less likely. Squamous cell cancer of the lung is usually due to a long history of smoking and drinking, and it tends to coincide with difficulty swallowing as well as weight loss. So that hasn't been happening here. Multiple myeloma is a possibility, and we definitely are going to want to investigate for that. However, with a lot of multiple myeloma patients, they complain of bone pain. Sarcoidosis is a possibility. She's a young woman. Typically, we see sarcoidosis in young women, and so this is something that we are going to want to look for. Familial hypocalcemic hypercalcemia, definitely on the differential, and then, of course, the number one cause is going to be on the differential. So what are we going to do? We're going to get a CBC, a BMP that was already ordered. That's how we got our calcium and phosphate. We're going to get a parathyroid hormone level, a serum 125 vitamin D, and 125 dihydroxyvitamin D. You can also call it calcitriol. It's the activated vitamin D. We'll also get a 24-hour urine calcium. That's going to check for the hypocalciuric hypercalciuria. Hypocalciuric hypercalcemia. And then a serum protein electrophoresis. This is done to look for multiple myeloma. You could probably exclude the serum protein electrophoresis and even possibly exclude the 24-hour urine calcium and just get the PTH and the calcitriol and see what the results are of that, because if the results come back in the way we expect them to for a primary hyperparathyroidism, then you really don't need to do any more workup. But this would be a comprehensive workup for this patient. So we have a CBC that's unremarkable. The parathyroid hormone came back 72 picograms per milliliter. That's elevated. The serum calcitriol came back at 60 picograms per milliliter. That's also elevated. And the 24-hour urine calcium came back as 380 milligrams per 24 hours. That's elevated. The serum protein electrophoresis came back as normal. So what's the most likely diagnosis here? We have an elevated parathyroid hormone, we have an elevated vitamin D, and we have an elevated 24-hour urine calcium. So the most likely diagnosis here is primary hyperparathyroidism. So I'm going to just go over how we knew it wasn't some of those other things. Remember, with the familial hypocalciuric hypercalcemia, they would excrete, in the presence of having a high calcium, they would excrete less calcium than we would expect. So we would expect that he would be not elevated. She wouldn't be elevated here if she were hypocalciuric. So she's peeing out more calcium than the reference range, but that makes sense because she has high calcium to begin with. If she was peeing out a normal calcium, then that might be something to consider. But most importantly, she has an elevated PTH. And when you have an elevated PTH and an elevated calcium, well, that doesn't really make much sense, does it? Because when you have a high calcium, you shouldn't be having a high PTH because you're supposed to get negative feedback. And so that elevated PTH is what's causing the primary release of the calcium. So the PTH is elevated. And then, of course, the serum calcitriol, that's also elevated because, remember, the PTH is what allows for the final production in the kidneys of calcitriol. So that's going to be elevated too, as long as you have an elevated PTH. So this is, again, you could go do a chest x-ray to make sure you don't have any bilateral hilar lymphadenopathy, so you can exclude anything else that you might have thought, any tumor or any sarcoidosis. But for the most part, the most important test you're doing here is the PTH, the vitamin D, and the 24-hour urine calcium. But this would all be part of a comprehensive workup. So primary hyperparathyroidism is the #1 cause of elevated calcium in the U.S., hypercalcemia. And what we get when we have hypercalcemia from hyperparathyroidism is just simply an excess of hyperparathyroid activity. And so you're going to have an elevated PTH, of course. You're going to have an elevated calcium as a direct result of that. You're going to have a low PO4 because remember that parathyroid hormone is responsible for also getting rid of the PO4 in the kidneys. And you'll also, if you were to test it, you'd also have a high calcitriol level, a high vitamin D, 125 dihydroxyvitamin D level, because remember, PTH helps convert the conversion process from 1 hydroxyvitamin D to 125 dihydroxyvitamin D. Patients who have primary hyperparathyroidism, it may be related to multiple endocrine neoplasia. Hopefully these things are in their family history, but occasionally they're not. So there are 3 different multiple endocrine neoplasia types. 2 of them present with hyperparathyroidism in many cases. So men type 1, that's going to be your 3 Ps. So your pituitary adenomas, parathyroid, so hyperparathyroidism, and pancreas. Men 2A is the hyperparathyroidism with pheochromocytomas. All right, and I talked about that in the medical section if you want more details on that. Okay, the symptoms of primary hyperparathyroidism. Now remember what I said, 50% of patients with hyperparathyroidism, which is is simply a laboratory diagnosis. It has nothing to do with your symptoms. 50% of patients with primary hyperparathyroidism have no symptoms. When they do, they start usually rather subtle and then get worse. It usually doesn't just come on as a coma. So some of the things that can start early on could be weakness, maybe a little bit of confusion, some bone pain, nephrolithiasis, maybe some hypoactivity, fatigue. But then later on, if it gets really, really high, you can get some of the more problematic things such as fractures and coma and lethargy. And so it's really important to look for the more common symptoms because it's probably going to be the common but non-specific symptoms that you're going to note. What the important thing is that you take out of that is that you know the symptoms of elevated calcium. These are all symptoms of elevated calcium, even though you can get a fracture from falling down, and you can get weakness from not having enough to eat, and you can get bone pain from stubbing your toe, and you can get abdominal pain from eating too much. If these symptoms coincide with diagnosed primary hyperparathyroidism, you need to treat the patient. You need to treat the patient for their elevated calcium level, and they need to be treated acutely on an inpatient level, or at least in the ED. And so what you should be doing is administering fluids. You can do normal saline, and you're doing this to induce diuresis. You'll also administer a loop diuretic, such as furosemide, and what you're doing now is you're getting the calcium out of the body. This is our efficient way of sort of flushing the calcium out. At that point, generally, we're good, and you can take serial calcium tests, and once you get into the normal range, then you're fine. If you still can't get the patient into the normal range with that, you can administer bisphosphonates, which can be done, I think they have injections for those. And those include alendronate and abandronate. They're typically used for women who are osteoporotic to help them get calcium into their bones. Basically the same thing we're doing here. We're getting calcium out of the blood into the bones. And so that can be added if necessary, as well as IV calcitonin, and that's done for more of a rapid reduction. But for the most part, what you need to know is the first thing you're going to do, and that is to give fluids and furosemide and then check the calcium again. Long-term therapy, however, is going to be to address the underlying cause, and virtually everybody who is young and everybody who has symptoms is going to get surgical therapy at some point for their hyperparathyroidism. And the treatment for that is parathyroidectomy. So we're removing parts or all of the parathyroid. Okay, so I want to draw a differentiation between these three types of parathyroid disorders. So all of these, this should say primary hyperparathyroidism up here. So all of these are causes of primary hyperparathyroidism. Now the vast majority of primary hyperparathyroid patients that you run into will be the parathyroid adenoma. So the parathyroid adenoma is 97% of all of your primary hyperparathyroid cases. It's just a single tumor. And so this is the parathyroid adenoma itself is the #1 cause of hypercalcemia in the United States. And it's just an autonomous, uninhibited secretion from a specific parathyroid tumor, which is a benign tumor, and it stimulates bone reabsorption and facilitates conversion of vitamin D and does all the things that it makes PTH, and that PTH does all the things that PTH is supposed to do. Now what's a little less common, but still present, especially in those patients with the multiple endocrine neoplasias, is parathyroid hyperplasia. And so this is only in about 2.5% of patients with primary hyperparathyroidism. What you would see here, and you wouldn't see this on your physical exam, but when you do a Sestamibi test, which is something that the surgeon is going to do once you know that you've got a primary hyperparathyroid patient that needs to be sent off for surgery, they'll order one of these Sestamibi scans to look for the tissue, and what they'll see is enlargement of the parathyroids of all 4 parathyroids. And so what you have here is just a generalized parathyroid hyperplasia. It's not just in one spot; it's in all 4. You don't need to worry about reading these Sestamibi scans for parathyroid hormone and any of that. I've never seen a question come up like that on the 3,500 test questions I've read through. But know that that test is around. And like I said, this has an association with MEN1, which is parathyroid, pituitary, and pancreas, and MEN2A, which is parathyroid, medullary cancer of the thyroid, and pheochromocytoma. Rarely you get the parathyroid carcinoma. This is similar in presentation to adenoma. However, early on you may have some hints. The hypercalcemia that you get from parathyroid carcinoma can be a lot worse than the hypercalcemia that you get from just a simple parathyroid adenoma. But that's not, there's plenty of overlap there. So you can't tell just based on the symptoms that, oh, this is probably a cancer and this is probably an adenoma. No, when you take your adenoma or your carcinoma out, whatever it is, you're going to biopsy it. And most of the time it'll come back adenoma. Sometimes it'll come back carcinoma. But if you go back to those patients who came in with the carcinoma, they probably had these significant symptoms of constipation, polyuria, nephrolithiasis, confusion, etc. Okay, so I want to distinguish now between primary hyperparathyroidism, which we've been talking about up until now, from secondary and tertiary hyperparathyroidism. As you know, primary hyperparathyroidism often necessitates surgery in parathyroidectomy. Secondary hyperparathyroidism does not necessitate surgery ever. Tertiary hyperparathyroidism may necessitate surgery. So I just want to compare and contrast these because there's a lot of confusion about these three things. So we're going to compare and contrast based on our parathyroid hormone level, our calcium level, our phosphate level, and our 125D level, which are all things that you should have in your initial workup of any patient who, of course, who has hypercalcemia. Okay, so what do we have here? And the thing that draws all these together, that's hyperparathyroidism, is that they all have elevated parathyroid hormone. So that makes all of these hyperparathyroidism. They're not all hypercalcemia, but they are all hyperparathyroidism. So primary hyperparathyroidism we just talked about, and remember what we get here. We get an adenoma or maybe a carcinoma or hyperplasia, and that's secreting parathyroid hormone, so that's going to be elevated. That's going to allow for more reabsorption of calcium, more vitamin D, and that's going to mean, because of the PTH, that's going to mean more expulsion in the kidneys, less reabsorption of phosphate. So, in other words, what's most important here is that you get the autonomous secretion of parathyroid hormone, the results being more gut absorption of calcium, more bone demineralization, more excretion of phosphate in the kidneys, and more production of 125D. How about secondary hyperparathyroidism? So now with secondary hyperparathyroidism, it's a little bit different from your lab results that you got with primary, other than that you had a high PTH. So it's still hyperparathyroidism. But now we have a low calcium and a high phosphate. Now that doesn't make any sense. Parathyroid hormone is supposed to help us reabsorb calcium and help us excrete phosphate. How come the calcium is low and the phosphate is high? And why is our 125D low when parathyroid hormone is supposed to convert our precursor to 125D? None of this makes sense. Okay, well, let's go back. So what we have here as the basis of the problem is chronic kidney disease. This has nothing to do with anything up in the parathyroids, anything up in the brain. You have chronic kidney disease. And the kidneys are responsible for doing two things, in addition to other things. They are responsible for getting rid of phosphate, which you can't do here because you have kidney disease. And they're also responsible for converting to 125 vitamin D, which is what's necessary to absorb calcium. So because those two things in the yellow can't work, you've got an impaired excretion of phosphate, so you have a high phosphate due to your renal failure, and you have an impaired production of vitamin D because of your renal failure. You're going to have an increased secretion of parathyroid hormone for two reasons. One, you don't have any vitamin D. Two, you don't have any, you have high amounts of phosphate, and phosphate is supposed to be telling the PTH to make more, because parathyroid hormone is what gets rid of phosphate. It helps get rid of phosphate. Now, also because you have the low production of 125D, the vitamin D, you're going to have an impaired absorption in the gut of calcium. And so that's going to result in a low calcium. And that's also going to help increase your secretion of PTH. So you can see now here that because we're not getting rid of phosphate because we've got bad kidneys, and because we're not making vitamin D because we've got bad kidneys, parathyroid hormone is pumped up in bulk here because there's no negative feedback. And what parathyroid hormone is trying to do is it's trying to raise up the calcium that can't go up because you have no vitamin D. And it's also trying to lower the phosphate, which can't be reduced because the kidneys can't get rid of it because you have renal failure. And so what this is it's secondary hyperparathyroidism. You have low or normal calcium here. But you do have hyperparathyroidism because of the low vitamin D and the high phosphate. Okay? So you've got to dissociate the word hyperparathyroidism with hypercalcemia because they're not always together. Okay. And how about tertiary hyperparathyroidism? So let's say that we got this person fixed up, we got their kidneys fixed up. A lot of times when you see this, it's acute on chronic kidney disease. We got their kidneys fixed up now, they're on dialysis, and now they can actually make some vitamin D, and they can excrete a little bit of phosphate because they're excreting it in their dialysis. So now what you've got is you should be normal, right? But, and this is the theory behind tertiary hyperparathyroidism, if you are secondary hyperparathyroidism so long, if you're in that chronic kidney state so long where you're like this for so long, at some point your parathyroids will just keep secreting parathyroid hormone forever. And that's what tertiary hyperparathyroidism is. So yes, when we treat patients with secondary hyperparathyroidism, they do usually go back to normal, other than their chronic kidney disease. But if it's been so long that they've had this, their parathyroids are going to be like, you know what, forget it. I'm not going to go back to making small amounts. I don't know what's going to happen, so I'm just going to keep pumping out parathyroid hormone the way I'm doing it. And so you do have a persistent elevated secretion of parathyroid hormone, and of course that's going to result in an increased gut absorption. You do have impaired production of vitamin D because you have kidney disease, but it is generally enough for absorption. And you also have some calcium coming in from bone demineralization. So your PTH and your calcium are both high. Your phosphate is also going to be high because you have renal failure. So that's the one thing down here that are going to maybe differentiate the two. But for the most part, you should be able to differentiate tertiary hyperparathyroidism from secondary and primary just based on their clinical history. So the big problem is going to be if somebody gives you a vignette and says, here's their lab results, what does this person have? Primary hyperparathyroid, secondary hyperparathyroid, tertiary hyperparathyroid, or none of the above. That you know the difference between primary hyperparathyroid and secondary hyperparathyroid. Primary hyperparathyroid is just the parathyroid pumping out parathyroid hormone, everything else working as usual. Secondary hyperparathyroid is a reactionary parathyroid. The parathyroid is pumping out extra parathyroid hormone because you've got low calcium because you're not making vitamin D. Okay? And because you have high phosphate. So, what do we do medically for these people and surgically? So, we talked about the primary hyperparathyroid people before. We rehydrate them, give them furosemide, then correct their calcium. We can also use bisphosphonates. Surgically, and that's going to be most patients, the surgeon will do a sestamibi scan to, that was those little pictures that I was showing you, to identify exactly what parathyroid it is, and then they can go in and remove it. For the secondary hyperparathyroidism, this is really no surgical treatment. You're going to treat the chronic kidney disease. You can give calcitriol, cinacalcet. These are calcium mimetics. Restrict dietary PO4 because remember that your PO4 is just going to stimulate more parathyroid hormone, and then PO4 binders can be given as well. But there's no surgical treatment for this, other than maybe a kidney transplant, but that's beyond what we're talking about here. And then for tertiary hyperparathyroidism, it's going to be the same as for secondary hyperparathyroidism, but in this case, if you really can't do anything medically to get their calcium levels down, then you can do a parathyroidectomy. So who goes to surgery for the parathyroidectomies? It's going to be all symptomatic patients, so acute symptoms, confusion, renal stones, osteoporosis, etc. And all patients who are young, and by young we mean young enough to not need a colonoscopy yet. So younger than 50. That sets a nice bar for young. Younger than 50. Basically what we're concerned about is the benefits to risks of a parathyroidectomy are significant, and for older people, do you really want to be operating in their neck? Maybe in some cases, but the general rule of thumb is if you're younger than 50, definitely best idea to get a parathyroidectomy if you can, because ultimately these will result in symptoms. Older patients who are healthy and asymptomatic can be observed, but that doesn't mean that they're necessarily not going to need a parathyroidectomy. And they can still elect to get a parathyroidectomy if their surgeon decides it's in their best interest. Especially if you got a 52-year-old, very young, very active, goes to the gym, things like that, it's fine. So these aren't rigid rules, but they're good rules to remember for the test. So like I said, nuclear medicine is used to locate the adenomas or the hyperplasia. And then the procedure itself is going to be based on whether the patient has adenomas, which is 97% of the cases, or if they have the four-gland hyperplasia, which is more of what you see in the multiple endocrine neoplasia. So if it's an adenoma, then that's a little easier. All we have to do is take out that particular parathyroid. The rest of them are fine. So that's a relatively easy surgery. Now on the other hand, the four-gland hyperplasia, because you have problems at all parathyroids, you have to remove all four of them. And the last one usually gets cut into a half. And sometimes it's placed somewhere like on the forearm, inside of a muscle. And the reason is so that if you have to go operate there again, you don't have to operate in the neck. Because operating in the neck presents all sorts of airway problems and surgical problems that if you can avoid it, it'd be great. So while you're doing this, so let's say we're talking about removing the solitary adenoma, which is done 97% of the time. The surgeon is going to remove the mass, thought to be over-secreting parathyroid hormone, and you're going to be ready to take blood. And blood is going to be taken at T-0 seconds, so right after it's removed. Then, and that's going to be your control. T at 5 minutes, and then T at 10 minutes. And what you're doing is you're looking for the drop. So if the PTH level drops down to half of the highest pre-op level, you could even so much say if it's half of TO, then the surgery is considered a success. Or if the PTH level drops into the normal range for PTH, the surgery is a success. If the PTH remains high, then you should consider looking for supranumerary parathyroid glands, which occur in about 12.12% of patients, and most can be found near the thyroid. There's some other ones, rarely found periesophageal, inferior to the inferior thyroid artery, and also some around the thymus, which would be inferior, an anterior portion from the esophagus. All the parathyroid tissue that you get out, you should, especially the one that's the adenoma, you should biopsy it. It will almost certainly come back as an adenoma. If it comes back as a carcinoma, it's not so much a big deal as in some cases. Carcinomas in the parathyroid grow really slowly. And so a lot of times removing the carcinoma of the parathyroid is enough treatment. However, it would need to be documented. Treating parathyroid carcinomas is outside the scope of this talk. You should monitor this patient overnight in the post-op wards with frequent calcium checks and EKG. Remember, this patient may go hypocalcemic. That puts them at risk for problems with their EKG. Two things you should be monitoring. Apart from getting your standard chemistry, you should be monitoring their calcium, and you should be monitoring their magnesium. And then, of course, on EKG. Some patients will develop signs of hypocalcemia. These patients should be treated as such. You can put them with PO calcium or IV calcium gluconate if necessary to get them back up to a normal calcium level. So again, for the four-gland hyperplasia, the surgeon removes 3.5 parathyroids and implants remaining parathyroid into a vascular-rich structure away from the neck. Typically, that's going to be like in the arm. And at that point, it slowly will develop a vascular supply, and it'll begin to function in 4 to 6 weeks. Yes, you will have your parathyroid in your arm, and it will be working. But it takes some time for all of those arteries and arterioles and venules to develop around there. It takes about 4 to 6 weeks. And so in the interim, the patient will be hypocalcemic because they won't have any parathyroids working. So they will need to take both calcium and vitamin D pills and possibly also vitamin D injections until the parathyroid is functioning. And so with these patients, it's especially important that you educate them as far as knowing the signs of hypocalcemia, tremor and deep tendon, excessive deep tendon reflex, perioral paresthesias, and then you'll want to recheck them at some point to get PTH, calcium, and vitamin D levels, some point between discharge and 6 weeks, and then you'll want to have a final recheck around 6 weeks with labs to make sure that everything's going fine.